Welcome to our Grand Round series. Our Greenberg bladder cancer team are grateful you're here. Of course, seeing you in person would be our preference, but given the ongoing response to managing the SARS-CoV-2 pandemic at Hopkins and our local communities, these virtual platforms have proven efficient for sharing information, education, and discussion. First, a couple of updates. Next month, Tuesday, December 7th, we'll be closing out the fall session with an important conversation on how genetic sequencing is leading the evolution of precision medicine for our patients and families here at the Institute. Later this month, we'll be releasing our winter and spring calendar 2022 virtual monthly programming. For updated information about the Institute, be sure to simply Google Greenberg Bladder Cancer Institute. Further, I wanted to once again draw your attention to our evolving group of programs, specifically tailored to the experiences of women with bladder cancer, developed and led by Drs. Armine Smith and Jeannie Hoffman-Census, and the program team of Pamela Getz, Samantha Rockler, and Stephanie Cooper Greenberg. Their next program is in December, and will be a conversation on life with and after bladder cancer, featuring a very well-respected panel of contributors. Their programming details are also available on our website, and of course, please never hesitate to reach out and we will send you the details directly. Again, all of this information and more is up on our website, and if we can help you directly, we are only an email away at bladdercancer@jhmi.edu. I'm incredibly grateful to all of you for joining us today for a conversation celebrating the role of the caregiver, recognizing those who are truly the unsung heroes in our lives. I hope you'll allow me the chance to provide a brief introduction of today's presenters. Lilly Shockney has dedicated her life to helping cancer patients and their families, both here at Johns Hopkins and across the world. At Hopkins, she served as the administrative director of the Breast Center from 1997 to November 2018, and as director of cancer survivorship programs from 2011 to November 2018. At which time we just learned she kind of semi-retired from her hospital leadership role. She'll probably have more to say about that in a minute. She continues to serve on the faculty at the Johns Hopkins University School of Medicine, and is also as co-developer of WorkStride, Managing Cancer at Work, an employee benefit developed for Hopkins employees that is now being utilized by businesses and corporations nationally. A two-time breast cancer survivor, Lilly has worked tirelessly to improve the care of breast cancer patients around the world. She's a registered nurse with a Bachelor of Science degree in Healthcare Administration from St. Joseph's College and a Master's in Administrative Science from the Johns Hopkins University. She has worked at Johns Hopkins since 1983. She's also certified as a breast imaging and breast cancer patient navigator. Lilly is the published author and nationally recognized public speaker on the subject of breast cancer, having written 16 books and more than 300 articles on the subject. She serves on the medical advisory boards of several national breast cancer organizations and is the co-founder and vice president of a national nonprofit organization called Mothers Supporting Daughters with Breast Cancer. Lilly is also editor-in-chief of a new peer-reviewed medical journal called the Journal of Oncology, Navigation, and Survivorship, which launched in spring 2011. She's the co-founder and director of the Academy of Oncology Nurse Navigators, AONN for short, a national organization that provides a network for all professionals involved and interested in patient navigation and survivorship care services to better manage the complexities of the cancer care treatment continuum for their patients. We're thrilled to have Lilly join us here today. We are also exceptionally grateful to Stephanie Cooper Greenberg for joining us today to lead this important conversation with Lilly. As co-founder of our institute, along with her husband, Erwin, Stephanie is a tireless advocate for bladder cancer patients and their families. In addition to her important work in bladder cancer, Stephanie serves Johns Hopkins on several boards, from the Children's Center to the Center for Innovative Medicine, and she also serves on the State Council for Cancer Control. Before the pandemic, it is entirely likely you may have bumped into Stephanie many days during the week with her therapy dogs making the rounds across Hopkins. A warm welcome to you both, and thank you so much for joining us today. Lillie and Stephanie have agreed to speak for about 30 minutes, and then we will jump to a larger group discussion. So I would ask folks to please submit your questions via the chat or the Q&A, and after their conversation, we'll have ample time for group discussion, and I'll moderate that.
Well, great. Well, thank you, David. Hi, everyone. I'm Stephanie. My proudest role is not the kind things you said about me. My proudest role is as a caregiver myself. And when we were putting this program together, we really thought it was time for the caregiver person, whoever you are and whoever is out there listening, or if you know a caregiver or live with one or are related to one, we want this program to be all for you. So the first person who came to mind when we were deciding to honor and acknowledge caregivers is the supernova herself, Lilly Shockney, who is done it all, seen it all, and can advise us all on the role of caregiving, and specifically in cancer care. And you're in for a real treat just with this session with Lilly, who's so amazing. First, though, I want to let you know a few things about caregiving. We are somewhat legitimate now in the sense that we're recognized as an entity in healthcare. And just to give you some really startling numbers, it's estimated that there are over 20 million caregivers in the United States over the age of 64 at any given time. That's for all caregiving, not necessarily cancer care. But when you think about bladder cancer specifically, there are over 80,000 cases diagnosed each year. So every case has a caregiver or two attached to that. So for all of you out there, we hear you, we know you, and we acknowledge that you do important things. The other irony, and we got just lucky, was when we put the program together, we did not know there was such a thing as National Caregivers Month. Bad us, but thankfully there is such a thing, and we thank you for being part. You're finally recognized nationally. It's kind of a Hallmark card moment, and thank you to all the caregivers out there who are finally being recognized. Caregivers are the primary source of care for older adults, people with disabilities, and people diagnosed with cancer in the United States. Most caregivers, as we all know, work and also provide care and experience the spectrum of responsibilities, from caring for the medical and logistical needs of a cancer patient, probably a shocking diagnosis that hit both of you. I'm just assuming it's maybe a husband and wife duo that I'm sort of referencing. It could be a daughter, a son, a relative, a friend. You all know who you are out there, but for the sake of this conversation, we're just going to assume you're a unit. Caregivers do things like scheduling, appointments, transportation, all of logistics regarding caregiving when a really devastating diagnosis comes along, be it breast cancer, in Lily's case, bladder cancer, any cancer. And we also provide emotional and hopefully spiritual support to our spouses or to our loved ones. Most caregivers are over 50, and sadly, caregiving is a really tough job at times. It can take its toll not only on the patient, but on the caregiver. We see increased stress, sadly, depression, anxiety, and also feelings of not being successful at what we do. We all wish we could be the ones who had the cancer and could will it away. And more often than not, that's just not possible, but we're there for our people. As difficult as it is to be thrust into a new job description, I'm sure that happened to all of you caregivers out there. You were a wife, a spouse, whoever you were, and all of a sudden you're a caregiver. It's the best job you never asked for, but it has its silver linings. And I'm sure that you will all agree that in addition to the stress and anxiety and dealing with uncertainty, which Lilly will belovedly talk about today, it's also, believe it or not, there's been research on caregiving. And what we didn't expect, it's done by our own Dr. Roth at the Center for Aging and Health at Hopkins. He identified and did this sort of longitudinal study. It's kind of bonkers that caregivers live longer. We thought our lives were going to be shortened by working so hard and being under such duress and adding this sort of other element to our lives. But actually, caregivers live longer. They have a stronger sense of meaning and purpose. They feel that they are appreciated, they're recognized, and that's all a good thing. So for all of you out there, we want you to know that this program is for you. We recognize what you go through. Lilly will help us navigate better how to be better caregivers, or maybe validate that we are caregivers, and tell her remarkable, remarkable story. So for all of you out there, we thank you for what you do, and know that you have a voice and you are never invisible to us. With that, I ask our fantastic speaker today, Lilly Shockney, to share a lot of her amazing wisdom and experience, not only as a pioneer in cancer care and patient and family services and patient navigation, and all the incredible innovations she's created at Hopkins and elsewhere nationally for breast cancer patients for over 40 years. But Lilly is also a survivor and caregiver herself. So with that, I asked Lilly to share her remarkable story with us and impart her wisdom, which we're all hungry for.
Oh, thank you so much, Stephanie. I really do appreciate that. So I'd have to go back to when I was 12 years old, was the first time I knew anyone who had been diagnosed with cancer. That was my mother's best friend. I consider her my other mother. Her name was Miss Bertha. And she let me into her life in an extraordinary way, despite my age, because she knew I wanted to be a nurse. And she said, since you want to be a nurse when you finish high school and then go on to nursing school, I want to tell you what I'm thinking and what's happening with me, because she was diagnosed with stage 4 breast cancer from the onset, and really had a rough road to hoe. But she, as I say, she let me in to see what that experience was like. And I now realize in retrospect, I was a quasi caregiver despite my very young age, because she would ask me to do different things for her, like, would you sing me a song that'll make me feel better today? Or can you read this poem to me? I always feel calmer after I read this, but I don't have the energy to read it myself today. And I think about her every day. When I was in my 30s, I ended up diagnosed with breast cancer myself. As someone who's an oncology clinician, I foolishly thought I should be immune from getting cancer if I take care of people with cancer, which of course is ridiculous thought, because 1 in 3 people will be diagnosed with a life-threatening cancer in their lifetime. 1 in 3, which is a whole lot of people. And we're not talking about skin cancer. We are including melanoma, but we're talking about literally life-threatening cancers. 1 out of 3 in the United States are going to end up traveling that very complicated journey. I really got a shock to my system in understanding what it felt like to flip to the other side of the side rail, because I had always been the one standing at the side rail taking care of a patient, and now I was the one laying there in the bed in a hospital gown. And I think when we put on a hospital gown, it has some power over us and has the ability to take control, and we can lose our common sense and lose our ability to think rationally and to think through problems, that all we can do is feel scared and feel very fearful. I was diagnosed again in my other breast at the age of 40. So I went through all of this all over again. And then 14 years ago, I landed in the hands of GYN oncology. So I think I'm working my way down. I think if I get toe cancer, I can feel confident that then maybe I'm done. At least that's what I keep telling myself in any case. I have served as a caregiver to my husband, who's had cancer 3 times in the last 15 years, but also for my parents. My mother was diagnosed with cancer when she was just 42 years old, and she's now almost 94. So she survived that when we really didn't think that she would. And I was in nursing school at the time that she ended up dealing with cancer and having treatment for it. My father has passed away of his cancer. He had metastatic prostate cancer, initially diagnosed with a much earlier stage, and then after 10 years after he completed his treatment, he was diagnosed with metastatic disease. And he was a challenging patient to take care of. Very challenging patient. He's been a challenging man all of his life. And he has been gone for almost 8 years now. And I'll give you an example of what I witnessed in serving in a caregiver role for him. So my mother and I serving in that role, that I went with him, of course, to meet with the medical oncologist who specialized in metastatic prostate cancer at Johns Hopkins. And I started off by saying, my father is a German farmer. That's really important that you know and understand that when you're talking to him about treatment options. And I realize in retrospect, I assumed that this doctor would know what I meant by saying he's a German farmer. And the doctor didn't know what I meant. So he just went, okay, and then said, well, this is the treatment recommendation I have for you. And my father said, wait a minute. I want you to tell me all the deals, like he was going to buy a tractor or combine or something. And so he said, oh, okay, well, there's, this chemotherapy regimen, and then there's this other one, and then this other one. Here's the side effects of each. Here's how effective we believe that they are. And that's why I'm recommending this particular one for you. And so my father said, well, you said I'm going to have chronic fatigue. I'm going to have nausea and vomiting. I don't care about losing my hair. I'm going to have numbness and tingling in my fingers and toes. It sounds like I can't be out on the combine picking my corn. And the doctor said, don't you think you should be retired now? Which was the worst thing he could say to this patient. So my father stood up and said, I'm done. I'm doing nothing. And I said, wait a minute, sit back down. So I said, how much do you know, doctor, about German farmers? And he said, nothing. And I thought, as a caregiver, I should have explained this, because why would this doctor know anything about that? I said, being productive is the most important thing to this patient. He must maintain his productivity. He was brought up to believe that if you are not productive, you should be dead. And my father shook his head, yes. And my father then said, when my daughter was young, we had a dairy farm. She was out there milking the cows. We measured the productivity of every cow, which we did. I think I could have been an operations management queen in another life, some industrial engineer. And he said, if a cow went 4 days with not producing as much milk as she had been, he looked at me and he said, what did we do with her? And I said, we slaughtered her. And the doctor said, well, Mr. Diker, you're not a cow. And he said, you don't understand. I've been brought up to believe I'm no better than one, which told the doctor everything. And he said, well, I'm not sure you are going to be out on your combine picking corn and soybeans. And I don't think you're going to be able to be out on a tractor planting your crops either. And I said, well, wait a minute. Farmers have seasons. Planting season in the spring, harvesting season in the fall. Right now, he's in the fall. And I said, couldn't you give this patient a drug holiday during his 2 busy seasons and have him receive his chemotherapy during his off seasons? And he went, huh, I hadn't thought about it that way. Yes, we could do that. My father then said, sign me up. So I, as a caregiver, needed to intervene and needed to be his patient advocate because he wasn't willing or able to explain why he wasn't going to retire, why this was really important to him, and how we might be able to negotiate how we're going to go about approaching this disease, knowing that we're not going to cure it by any means, but we want to get it into control while also having him have good quality of life. And part of his quality of life that was a priority was being a farmer. That was of utmost importance to him. My mother, in her caregiving role, I thought I had coached very well. When it was time for Dad to be in hospice and he developed his own criteria as to what he wanted it to be, is when I get to this point, I want to stop and I want to be in hospice at home. So he had been in hospice at home about 3 weeks, and he said to me, I want to go over and see my doctor again to personally shake his hand and thank him for taking care of me and also tell him goodbye. Okay. So I made him an appointment. I sent an email to the doctor and said, I'm bringing Dad over. When we got there, I thought we'd go in the consult room. And instead, the medical assistant said, no, the doctor wants you to go back to his office. I didn't even know where his office was. It was all the way at the end of the hall. And as I wheeled my dad through the door, the doctor said, there's no reason for you to be here today because you're at home now with your family. You're getting hospice care. And my father said, of course, there's a purpose for me to be here. I wanted to thank you for taking care of me, and I wanted to personally say goodbye to you. And the doctor said, but I failed you because you're going to die. And my dad said, we knew what the deal was from the start. He said, I expect to live through this. You told me I couldn't live through this. I understood what I was dealing with. You explained that to me very well. He said, but actually, I think I'm one of your success stories because I lived 5 years and you thought I'd only live 3. But my mother, the primary caregiver, says to the doctor, sir, I've been on the internet. I'm like, no. And I think I found another drug that my husband could have, another chemotherapy agent. And the doctor said, there are several more that he could have. And my father slammed his hand down on the desk and said, no, I'm done with that. I'm in hospice at home where I belong. And my mother said, Frank, why do you want to leave me? And he said, baby, I don't want to leave you, but look at me. I'm not living anymore. I'm just existing. You need to love me enough to let me go. That became one of my dad's legacies, which he didn't know about. But believe you me, when I heard that said, and my mother went, oh, of course. I say that to my patients that have metastatic breast cancer when I'm talking to their spouse, or it could be their daughter, could be their mom, and say you need to love her enough to let her go. Because caregivers will have a tendency to say, please do one more treatment for me. If you love me, you'll do one more treatment. And that's not fair. And my mother didn't realize that it wasn't being fair. She just wanted him here no matter how he was existing. Just his presence was enough for her, but it's not enough for the patient. So a key message that I learned very early on with Miss Bertha when I was 12, when I went through nursing school, taking care of patients, and then chose to go into oncology myself. The patient is the one that needs to remain in charge. The patient needs to let us know what their game plan is, though. Because if they don't, we could be operating on opposite ends, and that will be very unhelpful. A caregiver should never do an end run to the doctor and say, I'm going to talk my husband into doing this other treatment or signing up for this phase 1 clinical trial or whatever it is that maybe she's excited about. And the doctor went, oh, okay. But it's not okay. It needs to be the patient's choice. Unless you've literally become the healthcare proxy for your loved one because they are not mentally competent to make decisions, is when you become healthcare proxy, then please don't make those decisions. Do not try to call those shots. Sit down and find out what the patient wants. What does your loved one want? And buy into that so that you can understand it. Your loved one can explain it to you as to why this is so important. And we need the doctor and you and your loved one all singing from the same sheet music, because if we aren't, we're going to have a really big problem. My father wanted to hold the hand of his doctor, not shake his hand, but hold his hand. So he asked him to get up from behind his desk and come around and sit down beside him. And my father says, give me your hand. And he held his hand. And the doctor got very emotional. And my father said, you have a really hard job, don't you? Boy, you have a hard job. And I thought, I'm watching a patient comfort his doctor when I know this patient is going to be gone in probably 2 to 3 weeks, and he was gone in 2 weeks. I thought, what an extraordinary moment for me to witness. And I will certainly never, ever forget it. That's for sure. So we want to make sure that the patient is empowered. That is key. Empowered with accurate information so that they can participate in the decision-making about their care. And as a caregiver, you can understand what the choices are, but not make the choice on behalf of your loved one, but understand it and understand, how did your loved one reach the conclusion this is what they wanted to do? Because again, it's not our life, it's their life. We are supporting their decisions that are critically important at this time in their life. Maybe the last decisions in some cases that they may be making, for sure. And we also need to remember and sometimes remind the treatment team that the patient is more than their pathology. If I'm at a tumor board meeting and I hear a resident say, today we saw a 38-year-old white female who presented with a 2-centimeter palpable tumor in the left breast at the 2 o'clock position, I will say, excuse me, who is this patient? And don't tell me your name. Who is this patient? And the resident will say, well, I understand if I can't tell you her name. Who is she? Is she a 5th grade school teacher? Did she get a divorce last year and it wasn't her idea? Does she have a 9-year-old who's autistic? Is her mother showing early signs of autism? And she's now been diagnosed with cancer? Tell me who she is, or tell me nothing, because you're not qualified to take care of her if you don't know this person as an individual. So you may be the one as a caregiver speaking up and saying, my husband is an engineer and builds airplanes or whatever it is that he does, because he might be too shy to say, well, you know, this has been my life and this is what I do. And our job is a key part of how we identify ourselves. Absolutely, positively. Being a parent is how we identify ourselves. A grandparent is how we identify ourselves. A spouse is how we identify ourselves. So who is this person? You may need to be introducing your loved one to the treatment team.
That's leads to my next question. But Lillie, I've always wondered about that because, you know, especially with cancer, there's so many different facets to care. There's, you know, in the case of bladder cancer, it's an initial consult with the urologist, and then it may be chemotherapy, it may be oncology, it may be pathology, it may be radiation. There's such a big team and so many people involved, and you're sort of running around kind of to all these different places trying to coordinate care, which is hard for people who've never done it before in a system that we really don't understand inherently if we're not in the healthcare system.
Yeah.
So my question is really simple. You've actually already answered it. As the spouse or caregiver, in my case, you know, I wanted so badly to pipe up at times, but I felt like I'm not supposed to do that. Are we allowed to do that? To say, this is in my case, my husband, this is what he likes. This is an answer, you know, it's not informing the care team about who
Right.
you're dealing with. And oftentimes I think as caregivers, we're a little shy, or there's not enough time, or we don't want to waste anyone's time. Give us the scoop on that. Is it okay to do that?
It is okay to do that because you are advocating for the patient. And it's so important that the treatment team know who this is that they're taking care of. Including, you know, how is the patient doing with treatments? The patient might say, oh, I'm doing okay. But as a caregiver, you know that they've had their head in the toilet for the last 2 days.
Right.
Or maybe they're hiney in the toilet for the last 2 days, right? Or one end or the other, or maybe both. And we need to make sure that the treatment team has accurate information about what's going on with the patient. Patients oftentimes will not disclose everything to their healthcare team, either because they're afraid the dosage will be reduced or they'll be pulled off of the treatment.
Wow. Okay.
And though I appreciate that that's what scares them, that may be what happens, That might be the right thing to happen. Let's get to another drug that can work just as well, but not have the same side effects that we're having difficulty getting into control. So I had a woman who, her sister was her caregiver, family caregiver, and she actually told me in private, she said, I know my cancer is getting worse. She said, I can tell by the way I feel. And she said, my sister keeps saying, you don't look as well as you did a few days ago. Are you feeling worse? And I lied to her and told, oh no, I'm feeling fine, because I don't want her to know. And I said, that is very unfair. I said, because she's here for you. And the only way she can take good care of you as a caregiver is to know what's happening with you. I said, and the same for your doctor. And she said, well, it's funny you would say the doctor. She said, because I washed my wig and set it with the curlers. I put on makeup, which normally I don't. She said, I've even caught myself putting on makeup at home so I could fool my sister. And I said, the only person you're going to fool is yourself. Don't do this. Honesty between you and your caregiver, your sister, and honesty between you and your treatment team is how we can manage your cancer the best. I said, otherwise, another 3 weeks go by before you see the doctor, and then things are really going to be out of control. And the doctor's going, oh my God, I can't believe how far the cancer has spread in just 3 weeks when you knew it was bad 6 weeks ago. So I said, it could result in misinformation and sometimes even bad decisions, because somebody will think, oh my God, it's gone, you know, dry, it's just growing like Topsy, when it was already doing this 2 months ago. So I said, you owe it to your caregiver and to your treatment team. Always, always, always be honest.
So takeaway is for the caregivers to speak up and inform the team about the patient who may be a little more reticent about who they are, what drives them, who they are as people, and also how they really feel.
Right.
Things like scheduling and taking notes, because oftentimes, I think this happens universally, what the patient hears and what the caregiver hears, you know, particularly when it's a bad diagnosis, are like diametrically different. And if you write it down, you can sort of say, well, this is what he meant or she meant, and it wasn't as bad as you thought, or it was worse than you thought, or this is what the truth was. But
so first ask, can I record this on my phone?
Oh, you can do that? Oh, okay.
It is very rare that a physician will say, no, you can't record our discussion. Very, very rare. And if they do say that, I've got a problem with that doctor.
Okay, well, that's a great tip.
And so that way, the caregiver and the patient can listen to it again together and say, oh, yeah, oh, I see what you were saying. For example, let's say that the doctor said, this is stage 1, grade 3 cancer. But the patient thought he said stage 3, grade 1 cancer. Very different, right? First one is very early diagnoses. Other version is, this is far later, more advanced diagnoses. Totally different treatment, totally different outcomes usually. So we've got to start right there from the beginning and understanding what did the doctor say, because you can get those numbers flip-flopped and all the difference. I like to ask patients with the caregiver, they are listening to these answers, how much do you know about your cancer? As if somebody says, well, I have bladder cancer, but I also have bone cancer and I have liver cancer. It's like, well, wait a minute. I don't think you have 3 primary cancers. I think you've got one kind of cancer that has spread onto these other organ sites. So just clarifying, what are we talking about that you have, making sure that, again, we're singing from the same sheet music. And then how much do you want to know about your cancer? Some people want to know everything up front. Other people say, just give me just-in-time information. Give me a big picture, but for right now, just talk to me about surgery, because that's all I can think about right now. What are you hoping for right now? What are you most worried about right now? And tell me 3 things that bring you joy. Those 3 things are part of how that patient defines their quality of life. These questions I ask each time I'm seeing someone, particularly with advanced disease, and their answers will change for what are you hoping for? What are you most worried about right now? And tell me 3 things that bring you joy. If someone is still saying with stage 4 disease, I'm hoping for a cure, I'm hoping for a miracle, and we are way down that pathway, then someone has failed to have a candid conversation with that patient and saying, let's talk about what paths we will be taking, that we're going to treat this disease with the intent of controlling it and having you live in harmony with it and preserving your quality of life. But we probably will reach a point when I say, let's talk about what criteria you want to use to decide to stop treatment and solely preserve your quality of life, so you have time, more time with your family, more time with your loved ones, with your caregivers taking care of you. Because the worst thing that we could do is to have someone not understand what the final outcome we believe is going to be, and for that to be a horrific surprise if it's really bad news. If someone is how we approach cancer is also how we've approached other life crises in our life. It's not what we're dealing with, but how we react to it, right? That's where the rubber hits the road. And so I like to know, if you ever had anything serious happen to you before, and it might be an illness, it might be you got fired from your job, or you lost your job, or you got a divorce, or you lost a baby, whatever that it might be. How did you deal with that? How did you cope with that? And if I find out they didn't cope at all, that, you know, it was horrible and I'm still dealing with it and I don't want to talk about it, then I need to provide a lot of resources to help this person psychologically be able to cope with this.
It's also hard for the caregiver, because sometimes those beautiful, profound questions that you ask, sometimes it's hard for the caregiver to ask or have those conversations. You're sort of just going along trying to get everything, you know, in a system, and everything, all the wheels turning and all the appointments in place and all that. But sometimes there's a reluctance to be honest with your own caregiver. And I think that puts caregivers in a really difficult, leading to my next question, sort of stressful place, because they feel responsible in many ways for the diagnosis. They wish they could take it over and spare their loved one, whether you're the spouse or
Yes,
child of and so forth. But it's born out of immense stresses, but also great thrills too. I mean, I kind of remember some funny times. Now they're funny. They weren't at the time, where, you know, you're just really thinking, who is this person I married, and what happened to him?
Yeah,
And
where'd
then,
he go?
Like, where'd he go?
Left.
I have a few memories of, you know, wandering the halls, the aisles of CVS getting prescriptions filled, saying, I don't think I want to ever go home. But, you know, it only lasted for, 20 minutes. And, I bought shampoo or something and made myself feel better. But it's hard on the caregivers, because we think we know, especially in the case of spouses who we're dealing with. And we also know the red flags of when those medical questions come up, or that interaction between the medical provider, who's just doing their job as well as they can, and the answers. So there's always a tension. So my question, what advice do you give caregivers to sort of diffuse the anxiety, the tension, and also because cancer, and especially bladder cancer and breast cancer, which, by the way, the beauty of this conversation and the indignity is that breast and bladder cancer share many of the same mutations, which stinks. The BRCA genes are prevalent in both, and Dr. Mcconkey next month can decode all that for us. So they share a lot of the same genetics and mutations, but that doesn't, that links us in many ways. But how do you deal with the uncertain, caregivers alone and the patient deal with so much decision making and decision trees? Do I go in this direction? Do I get BCG? Do I have a TURBT? Do I get surgery? Do I remove my bladder? Do I go into clinical trial? I mean, there's so many decisions. And then the uncertainty of the outcomes and the uncertainty of waiting for your next scan. Can you help us with those challenges, which
Yes.
are
So part of
Yeah.
it goes back to that patient empowerment and caregiver empowerment of having the treatment team explain things in layman's terms so that the patient is empowered and can more confidently participate in the decision making about their care. We make decisions at a given time based on the information that we know at that time. Now, was it the wrong decision? A year from now, when we look back, was that the wrong decision? I don't look backwards. We can't go that way. So we made the decision based on the knowledge that we had and based on the advice that we've been given and what we're willing to do and not to do. And from there, we need to move forward. Anxiety of, for example, waiting for a scan to find out if the treatment worked. You know, that watched pot does not boil. I'm a firm believer in distraction. Well, I don't go to the movies now. I watch them on the television or Netflix or whatever. But factoring in some devoted time where you can't think about cancer. You're doing something totally different, and cancer isn't even allowed to enter that space because you're babysitting a 2-year-old or whatever it is that you're doing. Because we've got to have downtime from this disease. If we don't, it is in control of us. Why do we want to have cancer be in control of us? I don't want anybody to live that way. That I want you to give what it needs to get rid of it or get it into control. Don't let it take away any more of you than that. Not your personal time, family time, social time, or even your work time. Don't allow it. I am an avid believer in the value of laughter as a powerful weapon against stress. And when I was diagnosed the first time, I'd have to say that I've always been very witty, but I never spoke anything that was witty. I would just think it in my head. Now suddenly I'm saying funny things and witty things, and people are looking at me like, oh my God, Lilly, you've never said anything like that. Well, you know, this is where I am right now. I had family members and friends who didn't want to talk about the cancer at all. And I'd say, well, I want to tell you what's going on. I want to update you. No, I don't want to hear anything. No. Gee, you haven't called me in the last week, and I really wanted to talk to you. I want to talk about it. And I'm like, well, this isn't very fair. So I saw a commercial, an infomercial of crash dummies on the television getting us to wear seatbelts. And I thought, I have the solution to my problem. So when I learned I would need to have a modified radical mastectomy without reconstruction done, I called family and friends and I said, I found out I'm going to be getting a breast prosthesis in about 6 weeks. And I want to give her a name. She's going to be my bosom buddy. I'm going to take her everywhere I go. So I want you to help me select a name. So we had a naming contest. And I named her Betty Boob, is what I ended up naming her. And I sent out adoption notices that I had gotten Betty Boob. And one of my girlfriends mailed her a present. And it was in a box that said Betty Boob in care of Lilly Shockney with my address. And in that box was a ceramic Christmas ornament in the shape of a baby bottle. And inscribed on it, it said Betty Boob's first Christmas, 1992. So I would get phone calls, a lot of contact from people saying, how are you and Betty doing? When they were saying, how are you doing with your treatments? How are things going? When I got diagnosed a second time in my other breast, I contacted people and said, I found out Betty's getting a roommate. We need to select a name for her. And one day I hope to learn ventriloquism. I think if breasts could speak to the public, that maybe we could get women to get screening mammograms and do breast self-exams and get their clinical breast exams. And we can take the fear out of those words, breast cancer, by demystifying it, but especially putting the crash dummy picture on it, neutralizing it so that it's safe to talk about by kind of turning it into something else. Every patient that I've ever taken care of, ever, if I don't get that patient to laugh the first time I meet her, I feel I have failed her. And she's always shocked that she's laughing at something. I was on doing a Zoom call with a patient yesterday who's decided to do breast reconstruction. And I said, I had breast reconstruction done 10 years after my second mastectomy. I became medically approved for reconstruction. And I said, and I couldn't decide if I wanted to do it because I'd never done anything for myself. So should I just have Betty Boop and Bobby Sue and we just stay as we are, our boopsie twins? What should we do? So I asked my husband, he said, well, don't do it for me. I think we're doing fine. I said, we are. I asked my daughter, she said, please don't do it at all because I've seen you in the ICU too many times. And I said, no, it's been deemed that it is safe for me to do this. So I told this woman yesterday, I said, so I went to church by myself on a Friday night, didn't tell anybody I was going. No one was in the church, sat on the back pew. And I said out loud, I said, God, you give me a sign it's okay with you that I do breast reconstruction. And if you never give me a sign, that's fine. Because my boopsie twins and I, we've been fine. And I left the church not thinking I would be like hit by lightning or see a burning bush or whatever. Got out to my car and I thought, I'm not even telling my husband I went here to church tonight. Got in my car, put the key in the ignition, and my radio was playing. And the song on the radio I had not heard for 20 years. And the song was Sexual Healing by Marvin Gaye. And the first full verse I heard was, I can't wait for you to operate. I'm your medicine, let me in. I got home and I said to my husband, God just sang Sexual Healing to me on my car radio. I am going to do the breast reconstruction. And this woman said to me, I haven't laughed since I can remember. And it felt so good to thank you for getting me to laugh. And that is one of our best ways to reduce stress, is a genuine belly laugh. It also produces T cells in our bodies, which are the cancer fighting cells. That's good for the patient. It's also good for the caregiver. Every day we need T cells pumping through our body to prevent us from ending up being diagnosed with cancer. So laughter, I have a sign on my wall that I purchased at a gift shop when I was 13. It says, laughter is God's hand on the shoulder of a troubled world.
That's
And
so beautiful. Oh gosh, that
when you're stressed, I want you to find something to think about what I just said,
right,
and
right.
and laugh about it because it's pretty daggone funny.
Well, bladder cancer itself comes as such a surprise to most people, and it's a cancer they've never even heard of, let alone,
Right.
Know or skilled at. And it's also not unlike breast cancer. It's sort of a removal process, if you will. That's like the ultimate option, which is just a terrifying thought. I mean, it's macabre, it's barbaric, it's out of the Middle Ages when you think about it.
Mm-hmm.
Although
which again brings it similar to breast. When we remove a woman's breast, it's like, oh my God, we've
take away what
this, disassemble her.
Yeah, well, that's a pretty profound in bladder cancer with bladder removal. I mean, the whole intent is bladder preservation, but sometimes that's just not a good idea because you want to get rid of cancer, period.
Right.
I mean,
it's a trade-off, isn't it?
It sure is. But there's not much funny about bladder cancer, but
I don't know. I was thinking earlier when I finished my meetings this afternoon, and I thought, I bet you people with bladder cancer are really pissed off that they got it. So that's what I thought.
Well, that's a tagline, because we deal with, what a lot. So that's pretty funny. But no, they are. But also they're the most resilient group of patients ever. They're incredibly knowledgeable because up until recently, again, it's the invisible cancer. No one even heard of it. And then they become very self-educated. There are some wonderful organizations like the Bladder Cancer Advocacy Network and Yessi Institute and other institutions that have done a really tremendous job of advocating for and researching our way out of bladder cancer. And I would say that it's a golden age for bladder cancer right now, with a lot of new therapeutics, new drugs, new techniques and all that. It had been in the dark ages for forever, up until
too long. Yeah.
for too long. And the same is true with breast. I mean, there's so much new discovery and new therapeutics and progress, but it's
Mhm.
still pretty sad and depressing, and it's be
Tough.
sad and depressing for the
Yeah.
caregivers. So you have given us some remarkable tips. You know, one of the things as our role, it's again the role that we never asked for, but it's also a role that we would never trade for anything, because it has its moments of grace and joy and happiness and also purpose, and it continues on and on and on. So for all the caregivers out there, we thank you for what you do, and we know
Yeah.
that you are immensely important part of the team. I think breast cancer, any cancer, but particularly bladder cancer, is incredibly difficult to navigate alone. I don't know how some people do it, and
I
I
don't think they
give
should do it,
right.
right? There should be people on the treatment team to help with this navigation, whether it be a patient navigator or a nurse navigator. There needs to be a point person that the caregiver can go to and can say, wait a minute, I'm really confused. We've got 6 people that we're dealing with for all different things, and I don't know who to go to for what, or when do I call about this, or when will that happen, so that you do have some kind of a clinical pathway to understand who does what and what is to happen and in what order, just to be able to put together a calendar of when are the blood tests, when are the scans, when's the surgery, when's the chemo, when's the radiation, all of that. And we also, you know, I tell people, you do not get extra brownie points in heaven by being a caregiver and doing it all by yourself. You as a caregiver will have people that will call you and will say, tell me how to help. And the caregiver will say, oh, thank you so much. I'll get back to you and let you know. And you don't.
Mhm.
You should make a list of things. You need
Yeah.
Billy picked up from band practice every Wednesday evening at 7 p.m. You need somebody to get prescriptions picked up because you want to stay home with your loved one who's not feeling very well. You need food. Can somebody grocery shop for you? You can make out the grocery list and they can go and get it. Can you get some casseroles cooked that you can put in the freezer for when you need those? And I'll have caregivers say to me, well, I don't want to bother anybody. These people that are saying, how can I help, want to help. Otherwise, they wouldn't have said it, quite frankly. Right. And helping makes them feel better too. They're going to have their turn with something. They're going to have their turn, whether it be cancer or some other crisis, and you're going to be there for them. And you're going to be frustrated if they're not telling you how you can help. So make a list. These are the tasks that need to be done by somebody. And it is not necessary for you to be, you know, Wonder Woman or Superman, or because it can't be done. And you've got to take care of your own health. You know, it's like when you're on the, well, we aren't on airplanes very much now, but if you were on an airplane, a flight attendant will say, put your oxygen mask on before you help somebody else. And if you're not maintaining your own health, including your own cancer screenings, you could end up with a delayed diagnosis of cancer and be in a bigger pickle than your loved one is right now. And that would be a horrific outcome, not just for you, but for your loved one who's right now dealing with cancer, because they're going to feel very guilty about that. We also know that from research that on average, someone taking care of a loved one who has a solid organ tumor, which bladder cancer is, if they have been taking care of that individual for 6 months or longer, on average, during the first 9 months of caregiving, you will gain 12 pounds. And so it's like, well, I want to gain 12 pounds. How did I do that? Well, people bring you comfort foods, cakes and pies and chocolate mousse and pizza and all kinds of wonderful things like that. And your loved one doesn't feel like eating them because he's tired or whatever, but you'll eat them because that's one of the ways you're reducing your stress is by eating comfort foods. So you have to tell those family members and friends, I'd love for you to cook some things I can put in the freezer, but don't make it a cake. Don't make it a pie. Don't make it chocolate mousse. We need some healthy quiches in our freezer and such. And caregivers are not going to the gym to do their regular exercising. I need to be home with my loved one. I shouldn't be selfish and be going to the gym. It's not being selfish. We need you to maintain your own health. We want you on a low-fat diet. We want you to be exercising. If you can't get to the gym, then buy some apparatus in your home, and it doesn't have to be some expensive $4,000, gadget. It could be something for about $49, quite frankly. Just look online and you'll be surprised what you can get, and say, this is going to be my interim workouts until things are better and I could get back to the gym. But we really do want to make sure that you're maintaining your health, because if you get sick, then who is going to take care of your loved one?
Right. Such great advice. Actually, Pam Getz at Sibley, who runs our women's
I know
bladder
Pamela
cancer
very
program,
well. Yes.
She's remarkable. You sort of just answered her beautiful question about how caregivers can manage their own needs. Lillie, you mentioned something important, and we have a few more minutes left, but you have been a pioneer in I guess creating may not be the right word, but patient advocates and nurse navigators. A lot of us don't know what that is and don't know to look for that. Those people who are just saviors in terms of helping us coordinate care. In the few remaining minutes that remain, can you explain what that is and what we should be asking for? And before I let you answer, I just want to thank you from the bottom of my heart and everyone else here on this call for being so brave about telling us your own story, and also for the immensely great tips that you gave us. You gave us permission to be great caregivers. And there's no school, there's no manual. We were thrown into this job like we just didn't even know what the heck we were doing. We still are doing it and we love it. And hopefully it all works out in the long run, that your loved one that you're caring for is better. In my case, it's very much the case, but I still think I'll always have that little tagline of caregiver, which, it sounds like a good job to me now. It's a job I love and it's the best job I'll ever have. But back to patient and nurse navigators. Is that in all academic medical centers, or is it becoming more standardized, is my last question for you. And thank you again, Lillie.
Sure. So it is becoming more standardized. When I implemented nurse navigation at Hopkins back actually in 1995, it was because I saw that this is something that patients needed. First, they needed an advocate who was a member of the treatment team. They needed to have barriers identified that were going to prevent them from getting care efficiently or getting care at all. So nurse navigators and patient navigators will do what we call a barrier assessment. The most common barrier is lack of transportation. If a patient doesn't have a way of getting to their treatments, then they aren't going to get treated. It's that simple. Cultural differences can also be a barrier. There could be myths about cancer and whether it should be treated or not. Patient education is one of our solutions to barriers. So if a patient only knows people who have died of a certain kind of cancer and they've got early stage and we don't expect them to die, then we need to educate them and say, you know what, you're going to be the one that lived. And let's talk about how we can make that happen. They do serve as that advocate and the voice for the patient when the patient isn't speaking up for themselves. And sometimes they're speaking up at a tumor board where the patient definitely is not going to be, and the caregiver also is not allowed to be, because we're talking about many patients. So HIPAA applies and all that good stuff. But that navigator will speak up and say, I know that you're discussing having, choosing seventh line therapy or whatever it is that they're talking about for someone with advanced disease. That navigator will speak up and say, I've had a quiet, candid, honest conversation with this patient, and she's afraid she's going to hurt your feelings if she doesn't continue treatment. She's afraid you might be mad at her if she doesn't continue treatment, but she wants to stop. She wants hospice at home now. So that's a very profound way to advocate, but it is a way to advocate. Also, knowing the patient's milestones that are coming up. Let's say this treatment plan is going to take about 9 months. And you say, tell me, is there anything significant coming up? Your son's graduation? Is your daughter getting married? Do you have a 20th wedding anniversary on a cruise planned? Patients oftentimes will say, those things don't matter anymore. Just get rid of this cancer for me. We're going to work on that. But again, we don't want you to give cancer any more of you than it deserves. So if your daughter's getting married in 3 weeks, let's not do surgery in 2 weeks. Or you're going to feel like crap when you walk your daughter down the aisle, right? And to explain that it's safe to delay this by several weeks, that we want to preserve that milestone. We also want to learn, what are the patient's life goals? Where do you see yourself in a year, 5 years, 10 years from now? I had a young woman, 29-year-old woman, who was a bank teller. And I saw that she had a new shiny diamond ring on, and that she was fiddling with it. And I said, this looks new. Are you newly engaged? Yes, I am. When are you getting married? In a year and a half. I said, okay. And I thought, well, we will be done treatment prior to that, so we don't have to worry about dovetailing a wedding in the midst of all this. I said, I see that you work at the bank as a teller. Do you see yourself as the president of the bank in 10 years? And oh no, she said, I work at the bank because I like the hours that it provides me. It's what I do in the evening and on weekends that I'm passionate about, and that's my career goal, my life goal. I said, tell me what that is. She said, I'm studying to be a concert pianist. I said, oh, okay. And I knew we were giving her chemotherapy first and surgery second to shrink her tumor down. And the primary drug we were going to give her caused numbness, tingling, and pain in her fingers and toes, which could be permanent. So as her navigator, I got on the horn to the medical oncologist and said, we got to choose a different protocol, because we will steal away the ability of this woman to be a concert pianist if we give her this drug. So for sure, we did switch, and we told her why we were switching. And yes, she became a concert pianist. I also got her into fertility preservation, because she had hoped to be a biological mom one day, and now is a biological mom. Actually, she has 2 children and is a concert pianist. So we want to hold on to those life goals. I don't want a patient sacrificing them if they don't have to. Let's preserve those. Even if the patient has advanced disease, what can we do to fulfill those life goals in alternative ways? Let's say she has a 10-year-old daughter and she won't be here for her wedding when she's 25, 26 years old. She could write that daughter a letter to be read on that day, and she can have a wedding card for her on that day. What does she want to tell her daughter? How could she still instill her values and give her motherly advice and express her love? And believe me, she is right there with that daughter, because I hear from many adults who were children when I took care of their mothers, and they'll seek me out, even though they never met me. They know my name is Lillie and I'm still at Hopkins. And they'll say, you have no idea what these cards and letters have meant for me throughout my life, that my mother's presence has always been right at my side.
Wow, that is so profound and such great advice for everybody facing cancer. And
it's
wow.
that family caregiver who's the keeper of the cards, right?
That's
You need
right,
someone
that's right.
who's going to
So,
be taking care of those cards and letters.
We love so much about you, Lillie, but it's really about living and not living with cancer. So thank you for that. And we did have one last question about patient navigators in the Bladder program. And thanks to David Mcconkey and all the team at the Brady Urological Institute and at Sibley and Kimmel, there will be 2 new navigators in the new year. It's taken a really long time to onboard them. The postings are open right now. The pandemic sort of threw a monkey wrench in the plans, but
Into a lot of
thankfully,
plans, yeah.
Thankfully, that will be a resource.
And we have, just as members of the Academy of Oncology Nurse and Patient Navigators, we have over 9,000 members now.
Wow. Wow.
The majority of cancer centers do have navigators, whether it be a patient lay navigator or a nurse navigator. Sometimes a social worker is filling that role too. Any institution that is accredited by the Commission on Cancer is required to have a navigation program, to have navigators. Yes.
Thank you,
So,
Lillie. Advice, more advice we never knew about. So amazing. Well, I don't want to keep people past the hour. We could go on, talk all night, but Lillie, I can't thank you enough on behalf of all our
my
bladder
pleasure.
cancer friends and just friends listening in. You've been an source of inspiration to us, and you've given us some great advice, and from our hearts, we thank you. And thank you, everybody.
And to all those caregivers, have a good holiday with your loved ones.
You bet. You bet. Thank you, Lillie. And thanks everybody for joining us.
Yeah,
David, any last words? Our next
No,
program is,
you were a tour de force. Thank you very much, both of you, for doing this.
our
for
next
us.
speaker is David Mcconkey in December.
I promise not to show any gels or anything that will turn off my audience.
There you go.
You can
Thank
hold me
you
to
all.
it.
Good night. And most of all,
Thank you.
our huge thanks to our supernova, Lillie, who's incredible. Thanks again.
Thank
Have
you.
a great night, everyone.
Take care,
Bye-bye.
everyone.